Greetings to everyone present. Welcome to the CESA Technology and Engineering Innovation webinar, which will be focusing on engineering for healthcare. So my name is Phumelelo Dlamini. I am a civil engineer. I work for ACOM under Transportation and Highway Division. I am also an ESCA member for the CESA Young Professional Forum, and I'll be your facilitator for the day. So the agenda for the day is as follows. So firstly, I'm doing the opening remarks and the closing. We have 3 guest speakers, and we'll also have a Q&A sessions where you guys will be allowed to answer questions, and our guest speakers will give you answers. So our first speaker is Dr. Gift, and he'll be looking at the role of consulting engineers in healthcare, focusing on the perspective of the health technology practitioner. He will be followed by Paul, who will be looking at the impact of interdisciplinary engineering collaboration in the medical innovation. And lastly, we'll have Lendon, who will be looking at the role of engineering in enhancing health outcomes, community wellness, and optimizing health technology life cycles as a catalyst for universal health coverage. So basically, yes, the webinar is focusing on the impact of interdisciplinary engineering collaboration in medical innovation. So engineers play a pivotal role in transforming healthcare solutions, from enhancing patient care to advancing medical technologies. So in this session, we'll explore the critical importance of interdisciplinary collaboration across various engineering disciplines. We will discover how the fields converge to tackle complex healthcare challenges, drive innovation, and improve outcomes for patients. So get ready for an insightful session as we explore how engineering expertise is shaping the future of healthcare. So our first presenter is Dr. Gift Mbefu. Dr. Gift is the founder and managing director of a multidisciplinary engineering firm, MedTech Engineers. He is also a registered professional with EXA. He is also a board member of CESA, and an immediate past chairperson of the Gauteng Province branch. He also has served on boards of multinational corporates and in state-owned entities in the Republic of South Africa. Dr. Gift, the floor is yours.
Thank you so much, Spumelelo. Apologies. If you can just allow me to share my presentation. Right. Okay, just give me a sec. Can you see my screen?
Not yet, sir. Yes, we can now.
All right. I'm now on presentation mode. Can you still see it? Just to make sure.
Yes, we can see your slides and it's on presentation mode.
All right. Okay, thank you so much for the warm welcome. So, of course, as per your introduction, my name is Gift Mpefu. I'm the chairperson of the Technology, Engineering and Innovation Forum. This is a subcommittee of Consulting Engineers South Africa that focuses on organizing events of this nature. So we arrange a number of events, that focus on, digital technologies or digitization. And now we are very, very excited to host the first webinar that focuses on healthcare technologies. So good afternoon and welcome to all of you who have attended this session with us today. And of course, this is a platform for us to explore the intersection between engineering and health technologies. And of course, we do this for the advancement of the quality life for all of us. So the program today highlights, the presentation by distinguished speakers, Laden Poluta from Southern Right HTM Consulting, and Paul Lenger from WSP is currently based in the UK. And I must indicate that Laden is probably connecting from somewhere in the Western Cape. And of course, we'll have the Q&A session to explore new ideas and insights. You are invited to collaborate. This is your space to shape the future of engineering. My job really today is to set the scene. Of course, it's for us, before we get into the nitty-gritties of the presentation today as part of setting the scene, I thought that it's prudent for all of us to be on the same page, because I have seen in many situations that people have different understanding of the terminologies that we use in the healthcare space. So what are medical devices and how do they differ from health technologies? So I've decided to extract this definition that helps us to understand the concept of medical devices. So this was taken from the WHO. So it's important to understand that medical devices, as per the definition, refers to an article, instrument, apparatus, or machine. So basically, this is something that you can touch and you can feel it, with your hand. And that is a machine that is used in the prevention, diagnosis, or treatment of illnesses. So please keep this definition at the back of your mind, because as we talk about medical devices and healthcare technologies, we are not necessarily referring to the same. What is health technology? You'll realize that health technology is the application of organized knowledge, skills in the form of devices, medicines, vaccines, procedures, and systems, all of them developed to solve a health problem. So I'm sure you could see the medical device popping up in the definition of health technology. So meaning medical device, the concept that we defined earlier on, is a component of health technology and not vice versa. So it's very important for us to keep these two definitions at the back of our minds. When you look at the concept of health technology and try to understand, some of the latest trends today, you'll find that there's a whole lot of work that's being done in the area of wearable technologies. There's a whole lot of work that is done in the area of artificial intelligence and machine learning. And of course, we are all aware of the telemedicine systems. There is this new concept. I'm sure most of you would be familiar with IoT, Internet of Things. So in this case here, we are referring to Internet of Medical Things. So we have actually expanded on the IoT terminology as you know it to try to embrace the technologies in the medical space. And of course, there's a whole lot of work in the biotechnology, cyber security, as well as robotics. However, we are here today because the majority of us who are in this platform are doing some work, in the engineering space or in the built environment space. And therefore, today we wanted to dedicate this day towards really appreciating the contributions of engineering or engineering disciplines in the healthcare. So when you look at the healthcare as a system, you'll find that all engineers, play a crucial role in the advancement of the healthcare as a system. And not only with medical devices or medical technologies, we also touch on the actual hardcore infrastructure, as in buildings. So multidisciplinary approach or multidisciplinary nature of the engineering discipline is very, very important in the healthcare space. All engineering play a very, very vital role in the engineering space. I mean, in the healthcare space. Here, I've decided to take an example that shows the direct contribution of the electrical and electronic engineering discipline. For instance, these guys, the electrical, electronic engineers, are involved in the development of the telemedicine solutions. Telemedicine, smart healthcare systems for remote patient monitoring. Most of you would have come across this concept recently during our COVID pandemic. You would remember that it was difficult for people to consult in person, and some of the consultations were taking place remotely. Of course, the telemedicine did not start during the COVID days. It was the way, way, way before the COVID days. Of course, we've got biomedical sensors and some other medical devices, including pacemakers. I'm sure you know about pacemakers. So these are devices that are used to assist your heart whenever you have some, problems. And of course, the electrical engineers, electronic engineers are involved in the development of MRI scanners. Mechanical engineers, they are involved in imaging equipment, again with the MRI CT scanners. They are highly involved. They are involved in the design development of prosthetic devices, as you can see in this picture here, as well as medical robotics. Biomedical engineering, they are involved in actual instrumentation. Some of the medical devices that you find in your consulting rooms at hospitals or clinics or your private consulting rooms. So most of these patient monitoring systems are designed by these biomedical engineers, including the artificial organs. Of course, computer science and AI, professionals, they are very, very helpful in terms of helping us to uh, design the computer programs that we need to drive the robots to perform all those complicated surgeries. They are also involved in health informatics. You'll recall that there's a whole lot of enterprise resource planning systems that are being utilized in the health systems. So these computer science professionals are very, very helpful in terms of coming up with the sophisticated computer programs that are required to manage those systems. And of course, the very same computer scientists are the ones who help us with the artificial intelligence systems that are required for diagnostics. So there's massive opportunities and also massive responsibilities that we all carry as engineers. Number one, we need to harness the power of artificial intelligence so that we are able to solve the complex healthcare problems that we come across. Of course, with the understanding of the health burdens that we find ourselves, particularly here in the South Africa region. We need to address societal challenges with innovation and equity. And of course, we can't do this alone. We need to work together, as teams from various disciplines to make sure that we solve all these problems with the technologies that are available today. So I'm inviting you to harness the expertise of consulting engineering firms and engage actively in these discussions, challenge some of the assumptions and share some of the insights. We'll have an opportunity for you to do so, and commit to leveraging health technology for the betterment of all. So I would like to take this opportunity to thank you, and let me hand over to our facilitator for the day to introduce the next speaker. Thank you.
Thank you so much. Thank you so much, Gift, for that insightful presentation. We will now move on to our next guest speaker, which is Paul Langer. Um, so Paul has over 40 years of experience in the in the engineering sector. So Paul works as a technical director at WSP, and he is based in London. As a as a technical lead for the UK Building Technology Systems team, he oversees projects and develops strategies for systems integration in the healthcare, science, and the commercial sector. So previously, Paul led the US Building Technology Systems team for the Pacific Northwest. He brings extensive experience in the technology designs of hospitals, clinics, telemedicine systems, labs, and research facilities. So additionally, while working in the Silicon Valley, Paul has also collaborated with high-tech firms globally, working on projects ranging from standards developments, solutions qualifications, project tender, and design implementation. Paul, the floor is yours.
Thank you. I appreciate that introduction. Let me go ahead and share my screen. What I would like to talk about today is systems integration and cross-disciplinary work within buildings. When I started doing these projects 40 years ago, we would do some cross-disciplinary integration. We would tell the electrical engineer how much power we needed for our systems. We would tell the mechanical engineer how much cooling we needed for the systems, tell the structural engineer how much our systems weighed so they could engineer the building appropriately. But the systems, by and large, were segmented. They were not connected together. They did not share information, and the work was not done in a multidisciplinary fashion. The first opportunity I had to work in a true multidisciplinary fashion was about 12 years ago, working for the new medical center, new hospital at University of California at Mission Bay. They have a big room approach to construction where all the engineers and the designers would work in the same room. We wouldn't work segmented at offices. Some people spent full time there, some people spent a few days a week. But by having that ability to have instantaneous access to the mechanical engineer, electrical engineer, medical planners, we could work together and make a better hospital with better outcomes. So I'm a true believer in that work. My specific work is in smart buildings, and I think that as we move forward, smart buildings are emblematic of the way that systems will start to work together. Smart buildings are the glue right now that are going to hold these systems together. And so I'm going to use that as a focus moving forward for the next few minutes. Smart buildings have a lot of capabilities and a lot of benefits associated with them. They generate huge amounts of data. All the systems in the building today generates large amount of data. Lighting control systems, electrical metering systems, HVAC systems, even structural systems can generate tremendous amounts of data. Medical systems generate a huge amount of data. But all that data is essentially siloed and stored within those systems. And the idea of systems integration is working across these boundaries to identify ways to make the buildings work better and have better outcomes. We can save 10 to 40% on energy costs if we tie the mechanical systems to advanced indoor air quality systems. We can put additional sensors on the systems to make them operate more efficiently and to understand their life cycles and how they're operating at a particular moment. In particularly, critical areas such as operating rooms, we can monitor systems very, very closely for a tremendous number of opportunities for indoor air quality, for lighting levels, for airflow, so that we understand how the systems are operating and we can optimize the capabilities in that space. We can optimize, we can optimize workflow by understanding how the spaces are used and where people move within the spaces. And so by connecting the systems together, we can open up a world of opportunity for awareness and optimization. But in order to do that, we need to work across disciplines. When we talk about systems integration, we follow a specific approach to this. We want to shape the strategic outcomes. We want to talk about how we're going to what is it that we're going to do on a high level that's going to benefit the outcomes of the hospital. We want to develop solutions that meet those strategic outcomes. We want to interconnect the systems together. We want to enable data flows, and we want to commission the systems. Now, whether you're a mechanical engineer, an electrical engineer, a structural engineer, a systems engineer, a fire life safety engineer, a public health engineer, all of those systems have the ability to work together. And whether you want to focus on one of those systems or whether you want to focus across a broad range of systems, understanding how data flows amongst the systems and what data is available is going to be critical moving forward in working in this environment, especially in healthcare. I've had the opportunity to work on multiple different types of projects: labs, airports, rail, commercial data centers, and a hospital, because of the number of systems associated with it, is the most complicated environment that we engage in, and it's only becoming more complicated. The use of medical IoT, the use of telehealth solutions, the reuse of remote access for patients so that they can get treatment before they get to the hospital, the use of robotics, all of these things require data and require awareness about the hospital. That's going to require a multidisciplinary approach. When you look, this is a bubble diagram that identifies the systems and how they can interconnect within the hospital. When you look at the things that are connected to the building management system, which include public health and metering, electrical power quality, fire life safety, HVAC, facade systems, all those connect through the building management system. But in addition to those things, which we think as traditional building systems, you have lighting control systems, car park systems, electronic security, audiovisual, wayfinding, signage. All of these systems can interoperate and connect together and can share data so that information that we learn about public health can be shared with the computer-aided facilities management system. And so by interconnecting the data, we can automate those processes and we can make it easier for the operators of the facilities to be more efficient in their jobs.
Excuse me, Paul.
Yes.
Sorry, Paul. It looks like you have not shared your slides. So
I'm
if
sorry.
you don't mind.
Yes, they seem to be shared. So let me go ahead and reshare them then.
Please, yes. Thank you.
All right, my apologies.
Thank you.
So again, the idea is to let's make buildings work together for us. And we want to, in systems integration, we want to shape our strategic outcomes, develop solutions, interconnect our systems, enable data flows, and allow commissioning of the system so we know that they're operating correctly. And so this is where I stopped. Basically, what we're looking at is you have multiple systems within the hospital, and they all share the ability to interconnect together. But our role as engineers, as integration engineers, is to find ways to make that happen. Each of these individual bubbles is the hard work of independent engineers, but making them work together is the way that the hospital is going to meet the strategic goals. So the way we do that is by organizing those systems in a way that allows data flow through the hospital. This blue line through the middle is critical. That's the data network. And this is, everything that we're doing to share information is done based on an internet protocol data network. So this IP data network is really the heart for this. At the bottom of it, we have all the systems that are within the hospital, all the field devices, the meters, the fan coil units, pumps, electrical chillers, digital art, audiovisual systems, and those either directly or through gateways connect up to an IT network. They talk to local servers, and then from there they can talk to the cloud to do advanced analytics or to do large-scale connectivity. Because of this nature of having to take this information and share it across multiple systems and make it available to different systems, systems integration is multidisciplinary by its very nature. And so we work very closely with security engineers, audiovisual engineers, mechanical engineers, public health engineers, electrical engineers, sustainability designers, so that we bring all the capabilities of the system to a hospital, to a healthcare facility. In addition, as you're looking at this particular diagram, when you reach this cloud level, this gives you the ability to reach out to patients remotely. And so you need a way to get that data from the cloud back to a local device so a physician or a clinician can look at that data and understand it and interpret it to help with a good patient outcome. We typically use a 6-step plan in order to do this. The first step is we assign goals. What are the strategic goals of the organization? And this becomes the basis of the strategy. Everything needs to tie back to these goals. These goals can include a number of different things. At the top of the goals are organizational efficiency, which includes cost savings. If we don't have cost savings, if it's purely just patient outcomes, which are important, the cost savings are going to, the chances are that the healthcare organization is not going to be able to afford something like that. So we try to offset those costs by saving money elsewhere. If we can save 250 to £1 million a year in energy costs, those can be used for improving patient outcomes. Then we define use cases. So how are these technologies going to be used? When you have all this information flowing, there is a desire to use it for lots of different things, but that becomes difficult. It becomes difficult to implement. So we try to identify specific use cases. We're working with the NHS in Scotland. We're in the process now of defining use cases for their hospitals, and they include things like relieving bottlenecks on nurses, doing better scheduling for their medical imaging equipment, making it easier for their patients to come in and park. So again, in order to do this, we need to understand the architecture of the facility. We need to understand how it's scheduled. We need to understand the business use cases. At the same time, we have to follow a second path, which is a cyber IT path. As we put things onto the network, as we connect them together, we create vulnerabilities. And so we have to work with the IT staff in order to make sure that the systems that we're putting onto a network are done in a safe and secure manner. Then we develop solutions based on the use cases, what is available out in the marketplace as an off-the-shelf solution, or what needs to be engineered. And we need to make sure that those use cases meet the cyber and the IT requirements. And then we develop key performance metrics, because if you have a solution and you don't know what metrics you are doing to identify success, you're not going to be successful in the overall outcome, and you're not going to make sure that you're meeting your goals that you set at the beginning of the process. And finally, we help with procurement. How does this get specified? And this is where we really do a tremendous amount of multidisciplinary work. For the technology side of the building, we need to reach out to the mechanical engineers. So in their specifications, they identify requirements. And it's the same thing with electrical engineers, same thing with the architects. So we make sure that we don't just call our requirements out in one specification section, but we work across all the disciplines to make sure that these requirements and these approaches are met. So the overall outcome, when you start with a smart building, you start with very unclear goals at the end. And so our role as engineers is to work across the disciplines to understand what the opportunities are, to match them to the goals, and so that the outcomes for the patients, the outcomes for the clinical staff, and the outcomes for the business side of the healthcare organization are all met. And our roles as engineers is to take these ambiguous, difficult problems and to turn them into solutions that turn them into engineerable solutions that we as engineers can then solve. So that's my view on technology, and I will turn it over back over to our host.
Thank you so much for such an informative presentation. We will now be moving to our last speaker, Lyndon, sorry. Who so Lyndon, he has more than 40 years of experience. As a fresh graduate, he after graduation, basically in electrical engineering, Minland worked first in the medical device industry and then in the academics, like hospital settings, before joining UCT's Department of Biomedical Engineering in 1987, where he established the postgraduate diploma in healthcare technology management program. He has held a senior lecture position in the UP graduate school and from 2012 to 2015. And in 2016, he was appointed as the Director for Health Technology in the Western Cape Department of Health. He retired in 2022 and has served in advisory capacity and as a consultant for the WHO, the NDOH, and CSIR, and other national and international bodies. Menlyn, the floor is yours.
Thank you so much. Can you see my slides?
I can see your slide, but it's still on presentation mode.
Is that okay?
Thank you. It's okay now. Thank you.
So thank you so much for that kind introduction, and thank you also to Paul and Gift for setting a wonderful platform. This is totally unintentional, but I think our three talks dovetail actually very nicely. Thank you to CESA also for inviting me to be part of this important and exciting webinar. And most importantly, I think, welcome to all our participants. I can see there are over 100. It's fantastic to see so much interest in such an important topic. So I'm going to take, in a sense, take a step back from what Gift and Paul presented and focus not so much on the technology, but on how and what we do with the technology and how it contributes to the healthcare system, as well as to the broader health system. So that's why I've slightly tweaked my title from engineering in healthcare to engineering healthcare. And if I could paraphrase Paul, Paul spoke about smart buildings, and I would say smart engineering in healthcare. So this is a quote from World Bank, former World Bank president, which says, "It is not enough to build health clinics if there are no roads for mothers to gain access to them. People do not live their lives in health sectors or education sectors or infrastructure sectors arranged in tidy compartments. People live in families, villages, communities, countries where all the issues of everyday life merge. We need to connect the dots." I think for those of us in many, I guess in the UK, here and elsewhere, we get somewhat frustrated by the disconnects between the different government departments that work in silos, because we are coming from the outside to a community, and what we really need to do, if we accept this mandate here, is to actually move from the community outwards and have an integrated and seamless service delivery that will address the needs of that community. So the World Bank had this landmark publication, Connecting Sectors and Health Systems for Health Results. And it shows the health sector at the center of this diagram. But it also shows the importance of other sectors that actually contribute to the health sector's role and its success, emphasizing the importance of adopting, if we are serious about truly improving the health status of populations, about adopting a multi-sectoral perspective. And for those of us in South Africa, and the vast majority are, we all too well aware of what happens when there isn't that integration across multiple sectors. So maintenance, again, is one of the weak links if we look around us in the South African context, but also I think in many low resource settings and developing countries. Condition-based maintenance is not well done, poorly done, and sometimes not done at all. And of course, if an asset, an engineering asset, is not maintained, whether it's a hospital, a clinic, or a school, or a police station, then that asset ceases to be able to perform its primary function, in this case, a road, and it could be put to creative alternative use, but that clearly is not the intention. This is taken from the first comprehensive assessment that was done of our healthcare infrastructure shortly after the 1994 democratic transition. It was done by the CESA, Council for Scientific and Industrial Research. And at that time, it showed that the average condition of the estate, the healthcare infrastructure, was fair. But already, if you look at the fourth column at the maintenance type, there were a fair amount or a fair percentage that required backlog maintenance. In other words, we'd moved beyond normal or preventive or condition-based maintenance to actually repairs. And as you all know, as soon as we move into that zone, it becomes more and more expensive to return the facility to proper service condition. At that time also, Jeff Abbott at the CSIR did this exercise and looked at the budgets that were available relative to the need for what needed to be spent on retaining the health infrastructure estate. So you'll see the estate, a modern equivalent asset value. It was estimated to be just under 140 billion South African rands then. There's an estimate of 2% of that required for replacement, in other words, new facilities, replacement of existing facilities, 1% growth, in other words, for new facilities, and about 4% for maintenance. And the funding required for each of those is there, and you can see the total funding that was required was just short of 10 billion. What was available, however, in government across all the provinces was just over 3 million. So there's a shortfall then of over 6 billion rand in order to retain the estate, the healthcare infrastructure estate. I'm not going to get into the national health insurance discussion, but clearly this 15 years on is still a major concern and a major challenge for the public health sector in South Africa, but for the health sector as a whole. So getting back, and again, thank you to Gift for making it so easy for me. So medical devices are essentially a universe, and we break them down into sizable chunks or categories. And in no particular order, if we start at top right, we go from patient-based portable devices, CPAP, continuous positive airway pressure, of course, came to the fore during COVID and COVID-related interventions. So those are patient-based portable devices. Then we've got essentially our medical equipment, facility-based incubators, ultrasound machines, X-ray, and so on. surgical instruments, which comprise about a third of all medical devices. Then we've got our big ticket items, radiation oncology, MRI, linear accelerators, etc. And then from there, we move on to lab equipment, a lot of glassware, microscopes, but also some very expensive equipment. Then the rapid diagnostic tests, or in vitro diagnostics, as they are called. We all become familiar with these again as a result of COVID. Then moving on to all the medical consumables, of which are money, including syringes, wound dressings, and gloves, and of course masks, once again referring to COVID. And then last but not least, the implantable devices, whether these are with or without drugs. So a drug diluting stent would be an implantable device with a drug. And then, of course, and this ties up with Paul's talk, is we are in the age of information in healthcare. It's become pervasive, it's become important, and there are still huge disconnects in healthcare systems. There are huge disconnects between healthcare service provision and patients and communities. And of course, technology now affords us, in this day and age, affords us the opportunity to leapfrog and implement solutions that are forward-thinking, that are cost-effective, and make it easier for patients to access the health services that they need. So if we talk about healthcare technologies and infrastructure, we're really talking about technologies that focus on individual patients or clients. Whether those are clinical, as you can see, and those include the medical devices, pharmaceuticals, and other consumables, as well as the interventions themselves, or they are the importing supporting devices. We've looked at facilities and healthcare infrastructure. Emergency vehicles, of course, paramount in terms of connecting patients and communities to the healthcare system. Organizational and management systems, often kind of taken for granted or being seen to be an administrative function. And yet the greatest gains in healthcare delivery efficiency and effectiveness probably will come from interventions and innovations in the organization and management system space. And then, of course, ICTs, as has already been mentioned. So if we look at healthcare technology management, we've got three fields which are themselves highly dynamic, evolving, and of course interconnected. And so the challenge before all of us as healthcare technology stakeholders is how do we navigate this integration? How do we navigate this mix? As we've said, technology is coming at us at a rapid rate. Management, unfortunately, spends a lot of its time and energy putting out the proverbial fires, when in fact they should be preparing themselves, the institutions, and society as a whole for an uncertain future and managing or mitigating the risks associated with that. This is the health technology management life cycle. It kind of makes sense if you go from phase one, going all the way from planning and assessment through budgeting and financing, technology assessment selection, procurement logistics, Paul alluded to that, then installation commissioning, training and skills development, operation and safety, maintenance and repair, which includes refurbishment if appropriate, and finally decommissioning and safe disposal. So on paper, it looks fairly straightforward, it looks fairly simple, and of course we all know it's nothing but that. I quite like this definition of health technology management as optimizing the acquisition and utilization. So we can think of those two major phases, acquisition and utilization, because in a sense there are different primary stakeholders in each, of healthcare technologies to achieve maximum beneficial impact on health outcomes. So that's really the bottom line. And these are some of the benefits of good healthcare technology management. And I'm not going to read them, you can just glance through them. Of course, coping with increasing range and complexity is very relevant more and more. I'll come back to lifetime cost of ownership. I'll underline and emphasize maximizing efficiency, making best possible use of available resources. This is the ISO 55000 series on asset management, and this diagram is taken from that. It was based on a specification of the British Standards Institute, PAS 55. But if you look at it conceptually, it actually illustrates what healthcare technology management represents over its life cycle, from the bottom level up to the top or corporate or boardroom level as it is. And it's hard to make that connection between the basement and the boardroom and make sure it all functions in an integrated, efficient and cost-effective way. So this is just some examples now. Apologies for that. Some examples now from what can go wrong. So this is an example of over-design, and this is what was actually required. So that would have been the appropriate design. This leads to systemic inefficiencies and convolution of priorities. So top right is an example of an X-ray system that was procured for almost R1 million. It remained new and unused at the time of this audit, of which I was part of, and yet Sharps containers, which cost R400, are now particularly important in the context of infection control. There were none, so staff were left to their own devices and to make their own. This is taken from probably the only comprehensive audit that was done of public sector health facilities in South Africa some years ago. I won't mention the province, but just the bottom line is that almost 50% at the time of the audit, about approximately 50% of the devices were not being used for whatever reason. Approximately 20% were waiting for repair, about 10% were partly functional. But there were devices that were in good condition, fully functional, about 20%, and those were simply not being used. And this we cannot afford, literally or figuratively. I've spoken and alluded to the life cycle cost of ownership, or the total cost of ownership. Unfortunately, the focus is so often just on the purchase price. And the bulk of the cost of ownership, which is what is below the surface of the iceberg, is not considered or not provided for. So some of you may understand Afrikaans, but Afrikaans has got this wonderful phrase, goedkoop is duurkoop. In other words, buying cheap is actually expensive. Health technology assessment actually is one of the tools, methodologies that can play a very important role in addressing some of the challenges that I've outlined are also implied. And technology assessment essentially takes over from technology regulation. Purpose of regulation is to ensure that the technology is safe and efficacious. Technology assessment, on the other hand, then begins to answer questions like, can the technology work in this setting? Should the technology be implemented in this setting? And how should the technology be implemented in this setting? So very important questions that are asked. And by applying the tools of health technology assessment, many of them are cost-related, cost minimization, cost-benefit analysis, cost-effectiveness analysis. One can come up with smart approaches to the procurement or the acquisition and the optimal utilization of health technologies. So the goal of health technologies is really, of health technology management, is really to provide access and maximize the access in support of effective coverage. And this is the typical chain of events that happens. Going on from the previous slide, we go from health technology regulation, where, as I said, the focus is on safety and performance of devices or technologies, onto health technology assessment, which still, unfortunately, in many cases is applied just once in the technology life cycle, and that's at the point of entry, whether it's into the public health sector or the private health sector. And then there's the health technology management as downstream. If we divide that up into some of the steps, we go all the way from innovation on the left-hand side to safe disposal on the right. So that's the health technology management life cycle. But there are multiple valleys of death. Things do go wrong and can go wrong in going from one phase and one step to another. And so innovation is needed across the full life cycle, not just for new devices, new systems, new types of facilities, but innovation, as I said, is needed across the full life cycle, including asset management and organizational management innovations. And health technology assessment has got an important role to play in terms of where to leverage, where to get the biggest bang for our buck. What are the important questions that need to be answered? What evidence is there to answer those questions? And then transfer that evidence into appropriate, sustainable, cost-effective interventions. So health technology assessment is more than an access gate. It also becomes a mechanism for life cycle governance. Now, it takes a village. If we look at health technology management and who's involved, we see there are not only the health professions as the users and the non-medical professions, which include radiographers, medical physicists, and others, but also healthcare engineers and healthcare engineering cadres that are involved in health technology management. If we break down the healthcare engineering component, we have biomedical engineering. Gift alluded to this. This is largely academia-based, where new techniques, interventions, procedures are innovated. I should just mention in passing that at probably about 9 out of 10, the innovations that are funded and successfully at that level do not make it into the marketplace. Then we have clinical engineering, which is in industry, but also primarily in healthcare delivery, both public and private sector. Their focus is on medical equipment management and maintenance. Then we've got medical device engineering, which kind of bridges industry and academia, where the focus really is on innovation of medical devices specifically. And then last but not least, we've got hospital engineering, which is to do with health facility management and maintenance. Now, all these have got important roles to play. And again, if health technology management and the healthcare engineering contribution to that is going to be successful and impactful, it needs to be integrated. Right now, the Clinical Engineering Association of South Africa is waiting to hear from the Engineering Council of South Africa whether an initiative that started 20 years ago, namely to have clinical engineering recognized as a specialty within engineering, will actually be accommodated. We're still waiting to hear the outcome of that. There have been discussions between the Engineering Council and the Health Professions Council. The latter have now provided feedback on that matter to the Engineering Council. So we await with bated breath 20 years on to see whether that will be the case. Internationally, the International Engineering Alliance has now recognized that biomedical and clinical and other emerging specialties are indeed important as part of the engineering family and need to be recognized in their own right. The Ugandan Association of Medical and Healthcare Engineering probably is the model professional association in that it combines biomedical, clinical, and hospital engineering into one association. And in that respect, it perhaps unique. I'll just briefly run through this. This is just the House of Clinical Engineering, which points out some of the major components of the body of knowledge and the bodies of practices, because of course those will vary from region to region, from country to country, and perhaps even from sector to sector. But what is required is an important foundation, and that generally is generic engineering qualification, project management, engineering asset management, and technology assessment then are additional building blocks that provide a solid platform. Quality management and risk management provide the supporting structure if we look at this from an elevation perspective. From a plan perspective, this is just one profile of a particular clinical engineering cadre or community, and you look at some of the systems in which they are specialized. But as I said, those bodies of practice, they will vary from country to country, from region to region, from sector to sector. This is taken from a survey 7 years ago of clinical engineering activities around the world. Unfortunately, Africa at that stage was not included, but you can see the spread of focus areas for different countries. All of them, need I say, are important. There's no one that's less important than another, but it just indicates the variation across regions and across different sectors. So to end with, I represent the Global Clinic Engineering Alliance. It was established some 5 years ago. That's its webpage. It's an international not-for-profit. These are some of the highlights. It's got a global journal, which is now the top journal representing clinical engineering and health technology management in the world. That is its website. This is taken from one of its issues. It's open source and available to everyone. It also, Global Clinic Engineering Alliance, offers a wealth of resources. These are all open access and available to you if you're interested. Just the selection: digital health in low and middle income countries, empowering Africa's healthcare systems as examples, and then there are others. There are technology snapshots, which are shorter interventions, essentially an expert sharing his or her perspective on a particular area of interest. So now to conclude, let me just make a distinction, an important one, between the healthcare system and the health system. So we are all and have been largely focusing on the healthcare system, and rightly so. But if we look at the definition of health, and this goes back to the constitution of the World Health Organization, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I doubt whether we'll ever be in that state, truly healthy, will achieve truly global health. But that's really where the Alma Ata Declaration picked up from. It was a WHO UNICEF gathering in 1978 that spelled out the principles of essential primary health care. And it includes at least these components. And I outlined the importance of safe water and basic sanitation. So that is part of the health system. And the health system, particularly in this instance, safe water and basic sanitation, are upstream determinants of health status. And if there are issues related to water and sanitation, then these do have an impact on the healthcare system. So it makes sense to then adopt a broader health system approach with which the majority of essential interventions for universal health coverage can be delivered using primarily a primary healthcare approach. If we link this to maintenance, preventive maintenance is far more cost effective than corrective or repairs. And by the same token, essential primary healthcare is so much more effective in terms of determining health status of communities and nations than healthcare delivery, which again is downstream of that. So earlier we focused on the right side, on the individual focused technologies. If we now look at the ones that determine people's health, that are community focused, includes protection, housing security, vaccines, sanitation, roads, water, electricity, advocacy, education, and of course, nutrition, food, and very importantly, behavior. These are essentially the low-hanging fruits, and not forgetting environmental health. These are the low-hanging fruits of healthcare intervention. So it's an invitation to all of us. Yes, we are engineers. Yes, we work in healthcare delivery and in healthcare engineering. But let's not forget that there are huge opportunities and innovations required in the broader health system. And many of those are related to engineering as well. There's no reason why the community's water and sanitation cannot be addressed in the same way that a clinic or a road in that community is addressed. So with that, I thank you for your attention, and thank you again for allowing me to participate in this very worthwhile and important webinar.
Thank you so much, Lyndon, for such very informative and thorough presentation. And thank you also to to our other guests. So we will be moving to a Q&A session now. And our so everyone can type their questions on the chat box. Sorry about that.
Yes, Pumelelo, maybe while we're still waiting for the questions to be posted, let me ask a question to Mladen. Thank you very much, Mladen, for the great presentation, as well as to you, Paul, for sharing your insights in terms of the smart buildings, smart hospitals. But this is from Mladen. The audit results that you shared with us, you know, the audit that looked into the healthcare facilities and medical equipment and those type of assets. I think the information was very interesting and very, very detailed. And if I heard you well, the audit was done, you know, just after 1994. So my question is, has there ever been an opportunity where we had a similar exercise recently, or that was it?
Yeah, thank you, Gift. It's an important question. Yeah, so I mean, I do admit that that information is somewhat dated, although I cannot categorically say that it's not still representative of some provinces or some facilities. But to its great credit, the National Department of Health has instituted an Office of Health Standards Compliance. And with that, it set up a whole set of standards that actually is incumbent on health facilities to comply with. So before the office was set up, the COSASA, the Council for Health Service Accreditation of South Africa, had been doing these audits, essentially going to health facilities and evaluating health facilities across, I think, 12 different components of health facility operation against a set of standards. But as I said, that's been taken over by the Office of Health Standards Compliance, and they've implemented a very comprehensive set of standards, and they've been quite, I think, responsible and proactive in going to the provinces and doing inspections and doing audits of health facilities and reporting back not only to individual facility managers, but also to provincial and national managers in terms of the deficiencies that need to be addressed. So that system, I think, is in place, and I think that's commendable. The comment related to that is it all depends on what has been highlighted. I do think that there are still major shortfalls in maintenance of health facilities in particular. And of course, as we all know, there is a budgetary crunch. All government departments had to tighten their budgets last year. I know the Western Cape Department of Health had to. At one stage, they put a freeze on all non-technical posts. So if a technician, whether he or she was clinical engineering or hospital engineering, left for whatever reason, that person could not be replaced. So I think that, you know, the devil's in the detail, and I think we really need to get a systems view. So it's important to go in and to assess, but that assessment is just the start. So that outlines what needs to be done. And then the question is, are the resources available, not only in terms of budget, but also skills and competencies? Are they available for that to be rectified? But yeah, I think, and the one major drawback is that South Africa does not have a comprehensive asset management maintenance system, particularly for health technologies. And one could also say for health facilities. So, for example, the Western Cape has developed its own, but there is not one single integrated system, and that probably is the biggest drawback for NHI implementation. If we don't implement that, we'll always be on the back foot because we simply won't know what we have, what we own, the condition it's in, and what needs to be done to ensure that those assets continue to function as designed and as desired in terms of service performance. It's been a disconnect between National Treasury and the State Information Technology Agency. And I think that's frankly, it's now no longer acceptable. I think there needs to be a lot of noise, quite frankly, generated around this issue. And I think as engineers, we need to be part of agitating, for that to happen. And I think engineers have got a very important role to play in that space.
Yeah. All right. Thanks for that. But on a different note, we as engineers, of course, we work with a number of stakeholders, especially given the setting of a healthcare environment. How important it is, or what are some of the challenges that we are experiencing from a healthcare engineering point of view that really makes it difficult for us to ensure that these investments that we continue to make in these high ticket items, like this very, very big and expensive equipment, are underutilized, and yet many of the people are not able to receive the type of healthcare intervention that they need.
Sorry, was that a question or a statement?
Yeah, no, it was a question that to say that, how can we work together with other stakeholders within the healthcare system to ensure that investments that we make on these expensive medical equipment, medical technologies, health technologies, do actually get to benefit the public out there. What are some of the strategies that we can put in place to ensure that we are able to come out of that situation?
Well, I mean, my answer is simply, basically what I've shared in my presentation, Gift. It's about, proper healthcare technology management, and also having systems in place, information systems, organizational systems in place. It's about capacity development and capability building of the workforce. There needs to be cooperation between the medical industry, if you like, or the hospital industry or the healthcare industry, and academic institutions and training institutions, as well as healthcare providers, both public and private sector. So it's really just, we know what is needed, we know what needs to be done. It's just that there are so many disconnects, and whether NHI as if you like, as a centralizing mechanism could actually help that or make matters even worse, I don't know. But I mean, my own example as Director of Health Technology in the Western Cape, I would say that from my experience, that the Western Cape really does achieve the bulk of what you have suggested needs to be done in terms of providing access to communities. Of course, the challenge is rural communities, and telemedicine, telehealth, tele-maintenance have all got an important role to play. So again, there are solutions available currently. I think too many managers and even health professionals are just so busy fighting the fire at the proverbial, coalface, that there's not enough time, there's not enough energy, there's not enough opportunity, in a sense, to step back and say, what are we doing that should be done better, that should be done more efficiently, more effectively, and how do we do that, and how do we maximize the integration of all the stakeholders, including industry and people even in this discussion. So perhaps it's not the answer you were wanting, but I mean, it's really just about implementing what we already know needs to be done, but having the collective will to do that, to identify what needs to be done, and having resources available, and where resources are not available to the extent that they are desired, then how to make do with less and how to make more with less.
All right. Okay, thank you. Thank you for that, Madam. And to Paul, I actually liked your approach to the smart hospital, as a system. And the fact that you mentioned that the hospital, as a system generates a lot of data. And of course, this data is generated by the different disciplines, and the importance of putting together and integrating all this data so that you can extract some intelligence out of it is important. My question is, what has been your experience, of course, from where you are based, in terms of, integrating all these systems, coming from the different disciplines? The reason I'm asking this question is because, recently my team was involved in a project and, with one of the public sector clients, and a simple integration of a power system where we had to integrate, renewable energy, backup generator, and the normal grid system was just a terrible experience. And we still continue to see those, bad experiences from time to time from an integration point of view. So what has been your experience from where you're connecting from, Paul? Is Paul still on the line?
He is. He's muted. Paul, you mute.
So unmuted. So my experience has been quite varied. It is new, and the concepts are new. We did integration of our entire office in London, and that has been an extremely positive outcome. We're saving 80% on energy costs over year. There were challenges associated with that. I have also encountered projects where the ambition of the owners has been very high, but the actual appetite for spending the money to do it has been very low. So to address your specific instance, where we find these opportunities fail is usually because they're not thought through from inception to the end. So we think we can take information and we can meld it together, but we don't think about the steps ahead of that. What are the protocols? How do we make sure that it's secure? Thinking about through all those steps before and all the steps after. How do you validate that the information that's being generated from this integration reflects the actual information that's happening in the field? We did a project in San Diego for a large hospital that was very San Diego, California, that was very forward thinking. But the building engineers were not comfortable that the information that they were receiving on their computer screens was accurate. So they actually asked us to install video cameras on the displays in the machine room so they could see that remotely as opposed to trusting the data we're providing. This is all very new, and I think that the experiences are going to vary widely. I believe that it's going to get easier over time. I believe that the major manufacturers of mechanical and electrical systems understand what the requirements are, and they're starting to address them. But it is like any new technology. It's going through its difficult phases, and the efforts that you went through for your integration made you smarter about what needs to be done. So the next time this comes up, though, a lot of those issues that happen will no longer occur. So we have to mature as this marketplace matures.
Okay, thank you so much for that. I think it will be very interesting to, check the developments in that space. And I must indicate that on this platform, we talk a lot about digital twins, as part of our digitization and digital transformation talks.
Mm-hmm.
And we have seen some elements of the smartness that you spoke about in some of the concepts that were presented to this platform. So I think my team, my administrative team here, they'll make a note so that we follow up and see exactly what is happening in that aspect. All right. Spumelele, do we have the Q&A? Do we have any questions from the Q&A platform?
Yes. So as a young professional, what steps can one take to become an engineering expert in the health and medical innovation?
Okay. Let me get Mladen to respond to that because he's the right person to respond to that. Mladen?
Yeah, thanks, Gift. Well, I assume that one's got an engineering background. And then as I posted in the answer to one of the questions, it really depends on what your interest is. So you've got a choice of entering into, if you want to go into medical device innovation or research, it's a very exciting space. That would be biomedical engineering. And in South Africa, there are biomedical engineering departments at the universities of Cape Town and Stellenbosch. If you want to get into clinical engineering, on the other hand, the Tshwane University of Technology offers a postgraduate program in that, undergrad and postgraduate program in that. So that's to do with medical equipment management and maintenance, whether in the health sector or in industry supporting the health sector. If you want to get into hospital engineering, that's more generic because you're dealing with technologies and facilities and innovations such as those that have been outlined by Paul that are in a sense generic. And then last but not least, if one gets into, sorry, I've got a fade. Health technology management, the most important one, of course. How could I forget that? If one wants to get into health technology management, again, that's generic. One doesn't go into that, as an engineer. One goes into that as a manager. And so when I ran my program that Gift mentioned, there were health technology managers from, in fact, 13 African countries attended that program. Most of them were clinical engineering technicians. A few were engineers. There were some architects. There were radiographers. There were clinical technologists. There were doctors. There were nurses. So health technology management is generic. So I guess it really depends on, what you'd like to do, which of those areas interests you, where the opportunities lie. And once you've decided, which of those you'd like to enter into, then I think the path is fairly straightforward. But feel free to contact me offline after this if you'd like, any further guidance or assistance.
Thank you, Mladen.
Thank you.
Any more questions?
Yes. What role do engineers play in the government programs such as the NHI?
Well, I guess that comes back to me again. As I've alluded, I think they would play an incredibly important role for many reasons, not the least, and I go underline that again, to ensure that the infrastructure, the healthcare infrastructure, and that includes all the technology. So I'm not just talking about bricks and mortar and buildings, but all the technologies, including the smart technologies that Paul alluded to, that those are available at point of need, at time of need, in the right working order, in a cost-effective way and sustainably so. So that's a very broad statement, but I'm just underlining the fact that engineers as a whole have got an incredibly important role to play in NHI. But more broadly, if we look at the health system, they've also got an incredibly important role to play in society as a whole, because they can be the spark that actually drives the multi-sectoral approach to community wellness. As I said, where government delivery fails is that it works in silos, particularly when it comes down to community level. And if we flip that, and if we start from community level outwards, engineers have got a very important role to play in terms of integrating engineering assets that have an impact on health status of individuals and communities, and putting systems in place so that those themselves can be properly, managed, maintained, so that they serve their roles at the community level. So I've given you two kind of, contrasting scenarios, and I could go into the big middle, but just at the very high level of systems and the NHI, and at the community level, I think engineers have got a very, very important role to play that goes beyond, if you like, the scope of what we'd consider conventional engineering.
Okay, thank you. This one is directed to Gift. So Gift, can you please elaborate on the objectives of the Technology and Engineering Innovation Forum, which is part of the CESA Transformation and Development Committee?
Yeah, so thank you for the question. So, CESA Consulting Engineers South Africa, we have over 600 member firms that are associated with us. And these member firms participate in CESA on a voluntary basis, like myself and others. And of course, CESA caters for all the different engineering disciplines that they are out there. And as part of making sure that we keep abreast with what is happening out there in the technology space, in the innovation space, it was very, very important for us to set up the Technology, Engineering and Innovation Forum, as a platform through which we'll be able to organize, events such as this one, where we share knowledge, where we invite experts to come and, give us some information in terms of the latest trends in health technologies, in engineering, in various areas. So that is the whole purpose of the TEIF. It's basically there to ensure that there is continuous skills development or knowledge enhancements among the members of CESA. And of course, it's not only closed to CESA members. We also invite all the interested people out there to join us. That's why the invitations are also made public, for anyone who is interested to join us. So those who are interested, please get in touch with us. If you want to join CESA, please get in touch with me or Godfrey. We'll be able to give you the advice in terms of how to go through the process of being registered. Thank you.
Thank you. Can we go back to the NHI question? So they want Paul's perspective on the UK perspective on the government programs.
So I want to echo what Mladen said, which is from the government side, there is such a need for technical champions. We have hired a couple people who've come out of the NHS in the UK, and the information that we get from them is that the rollout of technology, the ability of technology to be rolled out to the hospital is really dependent on the technical expertise of the people in the specific region. So the ability for someone to say, this is important to my hospital, this is important to optimizing my utilization. So we see specific hospitals in specific regions where that message has become important, where they are clear about what their goals and their outcomes are. And then other regions where there's not an appetite to that because there's not a champion. The champions are usually engineers. They are usually the the people who have a vision for how to make something happen and the importance and the outcome of what will occur. The clinicians are looking for outcomes, they're looking for approaches, they're looking for ways to have better outcomes for their patients. Engineers are the ones who can help find those outcomes. And so I encourage anyone who wants to work in the public sector to engage that way. It is in many ways less about hard engineering. You're not going to be doing calculations. You're not going to be engineering a specific solution to a problem, but you are bringing engineering thought to the way that you advocate for these systems throughout the healthcare industry. And that also holds true for the US. Those healthcare institutions where there is someone who has a strong vision and has aspirations can make quite a difference moving forward. And I think that would be, obviously, South Africa has different challenges facing it than does the US or the UK. But I believe that having strong engineering voices in the government sector is what's going to really make a difference.
Thank you, Paul. Lyndon, you have your hand up.
Yeah, thank you. I was just going to say, and kind of linking to what Paul said, that the UK has got a national health system, National Health Service, NHS, and it's been operational since after the Second World War. And they've got their challenges as well. But I think, again, it presents a great learning and even partnership opportunity, because there you have a national health system, that's society-wide in operation. And there's lots to be learned from that in terms of, improving our own health system. Whether, NHI comes or not, there are still many lessons to be learned. And I think, again, there's probably insufficient collaboration. I know that the WHO does play a role in facilitating and publishing guidelines and that, but I think there's a lot that can be learned through literally observing and action learning. But while I've got the floor, I thought, let me just go down from, very high tech to very low tech. I just want to show you, I don't know if you've ever seen an X-ray tube. This is an X-ray tube. So when you have an X-ray or a CT, this is actually what generates the X-rays that are used to generate the image.
Very interesting. Okay, I'm looking at the time now. We don't have enough time left. Let me take this opportunity to thank Mladen for sharing your expertise. First of all, for accepting the invitation, and of course, for sharing your many years of expertise in the area of biomedical engineering as well as health technology management. And for those who are still on the line, I was in Mladen's class many years ago at UCT. That's where I learned my health technology management from. And thank you so much, Mladen.
Thank you.
And thank you so much. And to Paul, thank you for sharing your insights in terms of how you approach smart hospitals. And of course, we understand that you still have some challenges, but I think you have shared some very, very important information for us to start thinking about how we can actually contextualize, your approach in our setting, and we understand the process, the 6-step process that you have outlined with us. I think we found it to be very, very interesting. We hope to keep in touch with you as CESA for future events. So thank you so much, Paul.
Thank you for the invitation.
And I hand over to the facilitator to close the session. Thank you. And
Thank you.
Of course, thank you to our participants. Yeah.
Thank you everyone for joining us. We've come to the end of our session. Hope to see you again in our next events. Thank you. Bye. Thank you, everyone.
Thank you. Bye.